And on the side here, there's a little soccer play area for the kids.
I'm standing in the yard of a refurbished public school with a health leader named Francis Garwe. He's showing me the outside space at a clinic he leads in the east end of the Greater Toronto area.
And is this also through your philanthropy that you fundraise?
It's actually, this is Zero Ontario Health. It's our money, fundraising.
Yeah, that's amazing, Francis.
That's what
a vision to get the money to do all these things.
Francis is taking me on a tour of the Durham Community Health Centre. And so far, I'm super impressed. It's a rare glimpse at a community health centre that's pioneering a new way of offering primary care that's backed both by government support and community philanthropy.
But it's not easy. But what I say, when people donate, they really appreciate the real intended outcomes in that and what patients will get. People give where they see value. Yeah. So they see value in here. And I don't have to convince anybody that this is going to be beneficial for you. And
This health center serves a diverse population, including newcomers, immigrants, Indigenous and Black patients. And it's developed a culturally safe model of care that I think other clinics in Canada can learn from. It's a powerful example of a clinic not only serving its community, but that's actively leading the way in health equity with a community-centered approach. And for Francis, offering care that's deeply integrated into the community is a realistic goal, even as a nonprofit.
Do not let people tell you that as a not-for-profit organization serving homeless people and poor folks, you do not have to not have nice things. That's a misnomer. Homeless people and millionaires and well-to-do people in the community, we all want good life. Why not start from there?
I love that. That's so apparent here. Yeah. I think the other thing that's so apparent is the community.
Yeah.
The community is here, all in one place.
So that's what we are here for. And we serve everybody from birth to 100 years old.
Yeah, from once, just down the hallway, the youth and the seniors. It was beautiful to see that.
Welcome to our space.
Welcome to Primary Focus. I'm Dr. Tara Kiran, and we're here to imagine a primary care system in Canada that works for everyone. This season on the podcast, we've been touring innovative clinics and primary care systems that are both community-focused and equity-driven. A few episodes ago, we did a deep dive on how the primary care system in Costa Rica is bringing community-centered care to everyone. And then we toured a unique clinic in Vancouver that was built by community and the unique needs of the immigrants, newcomers, and migrant workers they serve. Today, we continue our series at this center in Durham, Ontario. And while they design programs and services to serve the Durham community, they're also leading the way when it comes to Black health. And so later in this episode, I sit down with Francis and two of his colleagues to talk about some of their unique services and programs, and specifically how they're trying to close the health gaps for the Black community they serve. But first, I want you to get a firsthand look at some of these programs and the amazing center they've built. So let's finish that tour.
Going beyond. We are very clear in terms of understanding who we're here for. So, our Durham, our community, our health, and our very clear, vision is stated here, building healthier communities together through values that, address all things in the quadruple M. We are innovative, trustworthy, collaborative, inclusive, as well as compassionate.
This is Francis again. He's the CEO of Durham Community Health Centre.
I'm also a chair for the Black Health Committee, which is a committee for the Alliance for Healthier Communities, focusing on the segment population for Black, which was an initiative founded and built during COVID to address some of the disparities that communities were facing in the mainstream of accessing care. We started from a place of this is a gap we need to address.
Francis has actually worked at the Durham Community Health Centre for over a decade.
We appreciate our role as a CHC. We can't do everything directly as a community health centre. We have to understand our part of doing direct service. It's probably the smallest part. The smaller part Everything else, as you notice, through our change theory model is how do we build collective impact so that we bring those partners who meet the needs of those services whom we are not best to serve. We are a connector as a bridge builder, but we also do a lot of work in advocacy. That is not a shortage in what we do. As an example, we are the only region in which Black health has been proclaimed by a regional authority for the first time in Canada. We did research to check who else has done this. Nobody else has done that.
The centre is located in Durham Region, a part of the Greater Toronto Area known for its mix of urban centres like Oshawa, Ajax, Pickering, and Whitby, as well as more rural areas like Clarington and Uxbridge. It's just on the eastern edge of Toronto, but covers a large swath of southern Ontario, all the way up to the bottom corner of Lake Simcoe. For this tour, Francis is showing me around their location in Oshawa South, but they also have clinics in Oshawa North and in Pickering, a community with one of the highest proportions of Black residents in Durham Region.
Did you say 39 to 40% of people in Durham are Black?
In Ajax area, the Ajax Pickering area. Yes.
39 to 40%?
Yes, those are the stats that we have from our assessment.
It's for this reason that we actually hosted one of the Our Care roundtables here in partnership with the nearby Taboo Community Health Centre and the Black Physicians Association of Ontario. One of the things that came out of that interview was the heterogeneity of the Black population and the intersectional identities that come into play here. What do I mean by that? Well, in our roundtable, we heard from diverse members of the Black community, including many new immigrants, some from the African continent, but others from the Caribbean, and many whose first language was actually French. These different identities meant people face different barriers, all of which intersect. They can face racism based on their skin color, but also xenophobia based on their accent. They may have different cultural norms and also face barriers to communicating in the language that they speak. We talked about some of these same challenges in our last episode on the Umbrella Multicultural Co-op. And there are definitely some parallels here to the work Durham Community Health Centre is doing in Ontario. One of those parallels is how thoughtful the leaders at Durham Community Health Centre have been about building out services that the community is asking for. And while the clinic provides primary care services to registered patients, many of their services are actually for the broader community.
In this hallway, everything we do in here is mental health counseling. So you have our MSWs who do this. We do DBT, CBT, individual counseling, trauma, marriage, all that happens here. And we have those services running in person and also running virtually. Mm-hmm. We are also one of the only team normally in the community here that you find where we have a diabetes team. Our diabetes team is a regional team. It covers the whole of community in Durham region.
But so not just patients here.
Not just rostered here, but everybody else.
The actual center, it's located in a renovated public school building. So there are long hallways with lots of small offices mixed with big, bright, open spaces.
The medical team in here, we have NPs. Hi, Melba.
Hello, how are you?
NPs, physicians.
As Francis shows me around, I have to say it really feels like a community. He can barely take 2 steps without offering someone from the team a friendly greeting.
Hey, Dr. Kiran.
How many do you serve in the clinic?
So we have about 7,700 and change that are rostered here in this clinic, but of which most of those constitute close to about, I want to say, over between 28 to 35,000 visits a year on all those services. This is, we call it our medication room, but our pharmacy. Yeah. We purchase medications for some of our patients who don't have coverage, so that at least, we notice that normally when you give them prescription, it doesn't get filled because they have to buy food, they don't have money. So we have a relationship with the pharmacy, which orders that medication at cost for us. We also run school-based clinics in 4 high schools, which our physicians, they go there from noon to about 3 o'clock when the bell rings, when the class is over. We see a lot of cases like STD, we do also vaccinations, etc.
In high school? In
high schools, so that those kids, because teenagers don't want to go to the same doctor as their mom and dad, so, but they can do that there. Yeah. These 2 rooms here, which you see senior and health and wellness, is our GAIN team, geriatric intervention network. And we do these services for the entire region as well. It's a regional program, not just for our patients. So other physicians, refer here. We serve massive number of patients that come in here. But on top of that is we also connect them with services that are very specific to them as seniors. And accessibility becomes less of an issue.
What's your wait list to be a patient here? It must be long, because I can imagine it's so attractive to want to be a patient here.
To be honest, I think we've cut it from 2 years to probably about a year or so, a year and a half.
Okay.
It used to be.
So you maintain a wait list then?
Yes, we do. We created a model which sometimes is considered a concierge model. The reason being, yes, you are waiting to be attached, but while you are waiting to be attached, we want to know what other things are you struggling with. Is that mental health? Is that food security? We put you in those programs so that you are not just waiting to be attached. You can access all these things. By the time you get to attachment, we have registered you into these programs that is also helping whoever is attaching you among our team to say, oh, you have already discovered things like diabetes you can access, hepatitis C, food security, you can do other things like geriatric intervention, because you don't have to be attached to get all those. We have a significant, large community garden. We raised this one here just for our seniors who are on wheelchair.
Can I open this? Is that okay?
Let me push it out. Yeah. Because seniors, when they come in, you will see when we get in there, the programs we run, they'll come through the door, roll their wheelchair and do their gardening up here, and everybody else does the gardening over there in the back.
That's amazing.
But social prescribing is one of the bigger pieces we do.
Yeah.
And it helps with social isolation a lot. We have here outreach team, indigenous, as you can see. All of our indigenous team, we have a team of about 6 team members, which we are actually writing grants because we are not base funded. So we write grants after grants to make sure that we support.
You probably heard the growing cacophony of kids in the background of this store. And that's because Durham Community Health Centre also hosts a really special after-school program. Of course, in what used to be a public school gym.
So tell me about this. This is like very dynamic in here.
Very. This is an after-school program which takes all the ages from 6 to about 18.
I love this.
And they come from all the feeder communities we have here. And the piece that you see here, this runs in with actually beautiful. James, I was actually about to explain your program. Yes. This is Dr. Kiran.
Hi,
nice to meet you.
Tara.
Tell her, what do you do here in terms of this specific program that we're watching?
Yeah, so this specific program is our Youth League after school program. So it's for children that are in grades 1 through 8. Mostly it's kids are coming from schools in this area that we know that are coming from low-income families and that need the extra support. The great thing about this program is I find that it's a good segue into other programs that are offered by DCHC that we know that these families could benefit from. But in terms of this program, we offer things like homework help. We have a STEM instructor that's here 2 days a week that does STEM-specific activities with our kids. We do different crafts, and part of what's mandatory for this program is doing some element of physical activity or sports. So we're lucky enough to have a gymnasium on site that we bring the kids to every day.
And food, it seems like as well, is a part of it.
Yep, we do. Food insecurity is a big issue with a lot of families in this area, and that access this program.
And so this is all free, I guess? And
all free for our kids.
Do you guys have a big waiting list? I can imagine every family probably wants to be here.
I try to maintain no wait list.
Okay.
So I don't have a wait list. I try to get everybody in as much as we can have capacity for. So I've never had a wait list just because I really try to, if we need more staff, we get more staff.
And how do people get here, like from the school? Do they walk?
James said some kids arrive from school by bus, while others get rides from their parents if the school's too far away from the center.
Yeah. And also one thing that we haven't shared here, we bring in also partners like this organization, Children and Youth Advocate Center of Durham, because some kids they're supported by both CAS as well as us medically. So we bring them in here. Mostly we deal with kids that are coming from very challenging families who are under CAS, and also kids who are facing rape victims. So they come in here. That's why you see DPRIS is in the Durham Regional Police. So they will do all their interviews here. Instead of sending this kid to the police for these interviews, they happen here. right? So that it's safe, and we bring police in here in their plain clothes. That also allows an
so then they
opportunity
don't
to
feel
be fair, to be fear-free, but also participate and be able to share evidence that's needed. Very, very important. When you do this in other areas where you take them to a police station, you definitely know what you're gonna get is bare minimum instead of getting the real support you need.
That's amazing. Yeah.
But also here, you notice, just like it's an industrial kitchen as you see it, during COVID, this was a hit. We were running kitchen just like you see on TV, which is why you see the mirror with videotape here. Even right now, we run this program with people at home. We send them all the ingredients in a big bag, khaki plastic bag. They are following the dietitian cooking in here, and then they are able to share exactly the same recipe. When they finish, they are eating their food. It's a beautiful way. We buy the food. All they do is to be present and participate. We buy all the food and send it home for them to do.
Wow.
We also run food security service here because we partner with Feed the Need Durham. Anything from sanitary hygiene items to dry foods. So if you have been here this morning, this was packed with eggs, milk, vegetables, fresh vegetables, and we feed every every Wednesday and Thursday about 110 families, and those families range from a family of 8, a family of 4, a family of 5, a family of 3 or 2. So that's why you see these are leftovers from now. We only do this 2 days a week. In here we have an industrial kitchen that we bring a third-party company to run, but at a very low subsidized cost. You can come in if you don't have lunch. You pick what you need. Starts from morning with coffee, and there's hot bar, cold bar, and seniors come in here every day, Monday through Friday, of course, and they pick what they need. And you will never get food like this anywhere else because there's funding coming also from Ontario Health that helps cover some of this.
There are also special areas specific to diabetes education.
In here is a demonstration kitchen, which the dietitian have. It's almost like a house. Yeah. When you look into it, so imagine when you have diabetes, Francis is your patient. Francis has to also teach his family on how to live. But this mimics your house, your sink, your stove.
Yeah.
So you bring a family here and say, Mom and Dad, now you have this disease in the house. You bring your boys or your kids, how do you prepare meals? So that's why everything is listed so that they can learn to use this space just like when they're at home. Now they know how to manage diabetes in the family.
That's amazing.
And
real life teaching.
Yeah.
Not just theoretical.
Yeah.
Another really amazing service provided here is childminding, which is offered through the Early Years program and the Parent Respite program. On Friday mornings and Wednesday afternoons in the summer, patients can drop off their children for 2.5 hours, either during an appointment they might have or for another reason. And the staff here care for their kids. Every child is even given a healthy snack.
What a great service for people.
Yeah. So if you're coming, say, for this appointment, instead of having mothers worry about, am I going to have a pap smear in front of my child? So you book the appointment up front, the registration desk, they'll take your child, and they book in with the room here so that your child is there.
To use this service, you do not need to be a registered patient.
You can decide to go to a job interview in Toronto for 2 hours or 3 hours, 2.5, to come and drop your kid. You can want to go have your hair done to a salon. You just come and book and actually leave your child as a member of the community. Drop and go, and you come. Your child is taken care of by the CECs, certified minders that are taking care of your child. Yeah. So in here, we also have a partner here with the Oshawa Senior Centre. Everybody who is 55 plus in Durham region, in Oshawa, they come here for senior center programs. So things such as pickleball, volleyball, cards game that they can do, all that happens here. That way we reduce them from facing all these challenges with social isolation. In here, is also a room that we use for seniors. We partner with brain injury, so they come in as a day program. They do arts and crafts, so everything you see here are the activities that they are doing all day. And these are the seniors that are coming right across Durham region, because Brain Injury Association of Durham is widespread. So, but this is where we spend most of the time. Again, this is the power of partnership. You saw our motto on collective impact. There are things we do directly, but there are things we bring partners in.
I think Durham Community Health Centre demonstrates how important what Francis calls the power of partnerships really is. Having all of these resources available in one building really is serving the community, and you can see it in action. Another important power, the power of fundraising.
Then over here, we also have an indigenous garden where we plant all the indigenous medicines because of the program we run. So the indigenous medicines are used for smudging and all the ceremonies that we run. So all the 4 beds that you hear, this was one of the first garden here for indigenous medicines, where we have sweetgrass, sage, tobacco. All these we harvest them. That's why we have a shed in there, that building you see in there. That's where we keep all the harvested medicines, so that at least we are able to keep them and we can use them. In the back here, you see there's a teepee, which we use for all the ceremonies. We are building a sweat lodge, so it's going to also be here as well, so that at least it allows to practice fully culturally for our indigenous programs and services.
That's amazing.
We're trying. And all this is because of the power of fundraising. Had we not been fundraising, we wouldn't be able to afford this, because the government doesn't fund it.
So this is through your philanthropy
activities.
According to a recent impact report, 88% of Durham's community health centre funding comes from the provincial government. But the rest they make up largely through funds they raise from private donations, grants, foundations, and other sources.
The reason we developed a program for development, which is fundraising and partnership, is because we understand government funding does not cover everything. This was the first CHC in Canada to build an internal fundraising portfolio supported by KCI. We did this during COVID. And the first year that we built it, we projected to raise about 45,000, and we shot that goal by March. We did about almost 462,000 first year of building that.
That's so smart. Because actually that was a point that some of our panelists made in one of the discussions we had in public member, that the fundraising strength is often in hospitals.
Yes.
And that's one of the ways in primary care continues to be disadvantaged, because we also don't have ways to gain philanthropy dollars.
Yeah.
I did this visit to Durham Community Health Centre back in June of 2025. And at the time, they were also in the middle of building a new outdoor space for patients. I'm told that project is now complete and the space is already being used by the community. Francis says it's really important to their team that they're offering truly holistic healthcare, so they build physical activity right into their model. The outdoor space includes a mini soccer field and a beautiful walking track.
You can walk with your provider. You can counsel your patients as you walk with them.
Oh, wow.
Yeah. So
and a playground for the kids. Oh, yeah,
for the kids and the physical activity. So these are the services that are in there. So it's coming out of a cardiologist out of Ohio who started seeing most of her patients having all these amputations and diabetic challenges. And he was doing this for the last 25 years, working with patients and counseling them on the track. This is what we are doing. So we make sure that, as a provider, work with your patient. Go out, walk with them, talk to them about the wellness. Sometimes it's a dietitian there or is an outreach worker there, so that at least we run a true holistic work. And on the side here, there's a little soccer play area for the kids.
And is this also through your philanthropy that you fundraise?
It's actually, this is Zero Ontario Health. It's our money, fundraising.
Yeah. That's amazing, Francis.
I think one thing the visit helped me reflect on was that to really serve the community in this way, you need more than the funding provided by government. I think it's one of the reasons why these types of programs aren't commonplace in all community health centers. I love how they're offering a range of programs, services, and resources to support the social determinants of health. They provide healthy food, access to social services, childminding, space and support for physical activity. But to do all these things, they actually need to rely on donors. The tour we just had illustrates how Durham Community Health Centre is serving its broader community. Next up, I want you to join me in a conversation with Francis and two of his colleagues to dive deeper into Durham's unique programs and services, and specifically how they're serving members of the Black community in a way designed to close the gaps in health outcomes. We know that our health system in Canada is just not meeting the needs of Black people. Black people have worse health outcomes than white people here in Canada, including more complications during pregnancy, higher rates of death from prostate cancer, and higher rates of being admitted to hospital or dying from chronic conditions like diabetes. These differences, they're just the tip of the iceberg because we don't actually routinely collect data about race in Canada, and so we don't know the full extent of the gaps in health. But it's important to note that the differences we see in health outcomes are not due to biology. The underlying reasons for the gap are really complex, but fundamentally, it relates to both interpersonal and institutional racism and discrimination, both in the healthcare system and in society in general. Racism that leads people not to seek care, partly because they're not getting the care that they need when they do seek it, but also racism that impacts what kind of job someone might get and the income they might earn when they have a high level of education. Understanding how we can close the gaps in health outcomes for Black people in Canada is really important.
Hi, guys. Hi.
Francis is joined by Akeem Stewart and Kirk Stewart.
Oh, wow. Are you related?
And no, they're not brothers.
Actually,
That's
just
hilarious.
kidding. I wanted to say they're twin brothers.
Well, you could be. You also got the same hair. Yeah, that's hilarious.
So my name is Dr. Akeem Stewart. Right now I hold the position of the Provincial Lead for Black Health and Wellness. The committee is made up of, right now, 17 community health centers, all working together for health equity for Black health across the province, with that one concerted effort and focus, making sure that we bring about the solidarity of what it would be needed for us to advance Black health for the whole Afro-Caribbean Black community of Ontario.
Mm-hmm. Can I ask, are you a family doctor or do you have a clinical background?
I'm an international medical graduate.
Yeah.
Did my internship in Cuba, and I would have graduated there as a family doctor in Cuba. Right now, I'm working in this capacity of public health, and with the goal to open up or work within the capacity of family medicine within Canada. Yeah.
That's great.
So I'm Kirk Stewart. I'm a family medicine doc over in Bowmanville, and I'm here at DCHC in the capacity of the executive lead for the Black Health and Wellness team, and also the primary care provider supporting that program.
To start off this conversation, I wanted to dig a bit deeper into the origin story of some of Durham Community Health Centre's programs and how they involved community in their creation. This first part of our interview is mostly with Francis, and then we'll hear from Akeem and Kirk.
Why the focus on Black health? Why that's important? What are some of the disparities, both in access but also in health outcomes?
Definitely. There were lots of things that became quite apparent during the COVID era. And those disparities existed even before COVID. Mm-hmm. What became a blessing and a curse at the same time is it allowed those things to come through a microscopic lens now. Mm-hmm. As an example, when we were talking about people accessing vaccines during COVID, one of the elements that as we spoke about the density of Black people in Durham, there was very little number of Black people who wanted to go for testing and also take vaccines. And the history speaks greatly about that. When you recall even the Botswana HIV era, the Tuskegee issues that happened, mm-hmm. Back in the day. So people don't forget.
People are
mistrustful. Those things. Yeah. So the mistrust of the system became a reality why people were not accessing. But also scientifically, as you remember, when we were looking at data for COVID by FSAs, we had a lot of our people, those that passed, they didn't pass because COVID was just impacting them. But there were also a lot of underlying conditions that existed that were a result of some of the cultural nuances in what we eat. And I think, yes, the cultural food that we eat are great, but what should we now understand deeper about things that we do with the food? We continue to enjoy the taste, but what do you do to make sure that you have moderation, but also understanding other things to keep you healthy? So during that time of COVID, we ended up taking a different approach to build trust became the first goal that we needed to make sure that we have not only in Durham region, but across Ontario as a whole. We even went into conversations as a Black Health table across the province to say, everywhere where we are doing the work, let's start with health education, health teaching, so that we build trust through that work. You recall the call out for community ambassadors, which were folks that come from the communities that they represent. Those ambassadors were uncles, aunties, sisters, brothers, kids of the communities that they represented, so that the knowledge is there.
So just go back up then. When did this community ambassador program start? It was during COVID?
In Durham region, we started right about the beginning of COVID.
Okay.
But the work had started shortly before when we were talking about building sustainable communities. So for the work that we were doing at that time, because again, without funding, we were engaging partner organizations, as you heard from Dr. Stewart, to bring them in to say, what can you bring as part of volunteerism to partner in doing this work? Because we didn't have a lot of structure within Durham to support Black communities, we partnered with Taibu Community Health Centre, which is back in Malvern, and the leader there, Liben Meka Gabriel, we brought him in, we sat down, we spoke about these are some of the things we needed to do. So we focused on two things: education and health teaching. So we set up groups that were focusing on women's health, men's health challenges, as well as youth work, to focus in Durham region. So when we began that work, that is the part that we started getting some feedback, the community ambassadors, to say, well, it's not as simple as you sending to me, say, a white health promoter, a Caucasian lady, or an East Indian young man, or somebody else from Europe. Are there people in the community that can understand what I do and what I eat and the places where I go as a Black man, so that at least I'll be able to open up? Fun enough, that first group for Black men, which were going into the Black Men Challenge, they opened up in ways that they've never opened up before to talk about, things that talk about prostate health, that talk about hypertension, and the impact of their social well-being. So we began to say, okay, so it's best for us to recruit within the communities. And that time, remember, zero payment. It was all about volunteerism. So those individuals became part of the early, I want to say, introduction of community ambassadors, because they spoke sometimes the language, they understand the nuances and the dynamics of the community. So when COVID now dropped on us, it was easy to go back to the trusted sources. And then they become the early stages of where we implemented community ambassadors along the way.
If you've listened to past episodes of the podcast, you might recognize some aspects of their community ambassador role in roles we've talked about before, like the cross-cultural health brokers at Umbrella Multicultural Co-op in BC, or even the ETAP in Costa Rica. In Durham, one of the strengths of their program lies in the recruitment of these community ambassadors who, like in BC and Costa Rica, are from the community it serves and speak the same language as patients. And Francis, Kirk, and Akeem tell me that that's crucial for building trust and providing authentic support for their Black patients, but also for newcomers, immigrants, refugees, and Indigenous patients. The Community Ambassador Initiative, it was initially grassroots, starting with community members working as volunteers. But what's so important about this community ambassador model is that it was co-created with their community. Through engaging community members and really understanding their needs, they saw the clear need for this role. The team says another key understanding that drives their work is that the community they serve, it's not a homogeneous group. Even in this room where we're chatting, everyone around me, they represent cultures from all over the world.
Exactly. Zimbabwean, right, Southern Africa, right at the tip.
And I'm from Barbados.
And I'm Jamaican. And Kenyan. So all different parts of the world.
Akeem says they may share the same skin color, but their languages, traditions, food, and belief systems, they're very different. And they make sure that's top of mind, both in the programs that they create and the information they offer.
Sorry, that it's so important to understand that the Black community is not a monolith. There's so many diasporas that actually do exist within it. So when we look at the idea of community and care, we can't give them a generalized view. It has to be specific to speak to each and every individual across the spectrum. And that's something that we all look at, especially when we go for strategic planning on how we can serve the community to its best, and why it's so important that we have a community focus-based practice this at Durham and at the provincial level. So when we go out and we put these plans out there, it's palatable and it actually works. We can actually see what the outcomes are at the end of it.
But how do you manage to address that, like the diversity, even in language? How do you manage to...
The community.
You mean, say more about that.
Yeah, the same people we invite to the table are the ones that are showing up. So if we invite them to the planning, where it's not DCHC who's going to have to take that responsibility or take that stance in making sure those needs are met.
So they will make sure that the language needs for their community are met, or whatever other needs, cultural, religious needs.
Right. So we've had other organizations, community partners that will show, and they pay attention to the marketing efforts. So we'll say, okay, these are the things that are going to be available to them. The room with the space, we had 3 major areas with multiple rooms sitting under those space. So we had one for a community market. We had one for health education, and then another space for screening. And with the organizations that showed up, they made sure that information was passed on to the community members that access their service. And with that, they made concessions for even translatory documents. One group, for example, it's called VRAE. There are therapy service that provide Francophone therapy. So when they showed up, they brought Francophone pamphlets. So you go over there, you're not gonna get too much on English. So they provided that. You would go over to, we had some representatives from the mosque in the area. They would bring over some of this.
All the community partners serving very diverse people together. And then they ensure that the needs of their community are being met. I mean, we heard again and again that people wanted the education, they wanted the empowerment, they wanted to be involved in how things were set up too, but they also wanted to know, how to manage their own health and have the tools to do that. So this is very much in line, when we talk to people across Canada, what they were telling us, broadly speaking, from a number of different communities. I guess, are there specific barriers that members of the Black community face? Understanding it's not a monolith, but I wonder if you wanted to speak a little bit to some of the specific barriers.
Yeah, so one of the ones that we're seeing specific to Durham is immigration. So we have an increased number of patients that we're seeing on our refugee status. And I'll put in there also a student visa status, which for all intents and purposes could be the same, depending on how you look at it.
Even more complicated.
More exactly. And so they come in, they're having a hard time accessing resources. Now, the hard time that goes with that is, remember, we're talking about Black people with refugee status. They've seen other people that are not Black with refugee status that have a different type of reception.
From who? Reception from who?
The health sector, the community sector. And it's not just in Canada. When I was in the States, when Syria was a thing, and even what's going on with Russia, communities would take them in, find the community members would find places for them to stay, even though they're refugee status. Similar experience here in the patients that are coming in. They have a hard time having access to certain services. They're not told about it. They're treated a certain way.
So you're saying, so they have, like, this is partly a barrier within society overall, but it also manifests in healthcare because they can't access some of the services, basically because people are discriminatory.
That's right.
Based on the color of their skin.
And because they're refugees, because
both of the things together. Yeah, there's
here's what I've learned about refugees. When I worked in the shelter system, I worked primarily with youth. Refugee, the one could listen to that and hear they're not doing well, they don't have any education. There's a lot of things that go with that. When I worked in the shelter system, the people that were coming through as refugees, these are well-educated young men and women that were fleeing real life stressful situations. Whether they were prince, they were doctors, they were coming down because life took a certain twist. That's not what
people conceive of,
right?
Yeah.
So when I do my encounters and I'm doing my meet and greets, I love to listen to their story, and I'm always blown. You know, I had 3 wholesales or shops in my community. You know, I was a principal at this. And they come here and they work in, not to put down any jobs, but the jobs that they're going through
require less education.
That's right.
So they're overqualified. Yeah.
But those are some of the challenges that's there with refugee status.
Kirk told me an account of some Black and Caribbean patients who described the discrimination they faced in a local hospital trying to get access for pain medications for sickle cell anemia. Sickle cell, it's an inherited blood disorder, and it predominantly affects people of African and Caribbean descent. But sometimes patients are denied pain meds because they're seen as just another patient trying to get easy access to pain drugs by doctors with little understanding of sickle cell anemia. These experiences of being misunderstood, dismissed, or just overtly discriminated against create a pervasive mistrust within Black communities. And that leads to Black patients avoiding medical care that they sometimes desperately need. One of the programs that Durham launched to tackle mistrust in healthcare for Black patients is called Kliniki, a name inspired by the Swahili word for clinic. The Kliniki Clinic provides access for patients of all ages who identify as African, Caribbean, or Black, and it's designed to provide full-spectrum primary care across their lifespan in a culturally affirming way. It provides chronic condition management, for example, for people with diabetes or high blood pressure. It supports women's health and provides mental health counseling, all areas where Black patients have traditionally seen much poorer outcomes than white patients. Kirk says that, interestingly, this intentional focus on serving patients facing discrimination has drawn the eye of a wider population. Despite launching Kliniki as a service specifically for the Black community, the clinic is now accessed by patients from other groups that have historically been poorly served by our system, including members of the LGBTQ+ community and people with accessibility issues. What they see in Kliniki is a rare opportunity to seek care that's sensitive to the discrimination they face. And while they and others access Kliniki because of the equity lens that's built into the programming, the core purpose of Kliniki continues to be mitigating anti-Black racism. On the Black health and wellness team in Kliniki is a manager, 1 full-time nurse practitioner, 2 part-time NPs, a community outreach worker, a youth outreach worker, a health promoter, and a medical secretary. And they're currently recruiting a family doctor.
And so that's the team that you're joining in when you sign up for Kliniki. So you're not signing up with Dr. Stewart.
Yes, you're signing up for the broader team. Yeah.
And I think that's where we're going to see the outcomes.
But also the community engagement.
That's right.
Yeah. And how often is this team running? Is it every day or is it?
So yeah, they're as I'm sitting here talking to you, they're doing
it's happening right now.
Yeah. And what we're doing, again, every year we have a focal point, which this year's agency. So this year we spend a lot of time with specific partners. So DDSB is one of them, the school board. We're spending time with them around having young people in high schools and elementary schools, working with them to demystify medicine, right? So coming out and having them touch a stethoscope or play with a blood pressure cuff to kind of build that interest, you know. Also doing that where they see a Black doctor do it.
Yeah, that's very different.
Station. That's right.
Role modeling.
Because of the challenges with access to public transportation in Durham, the health center has also launched a virtual clinic. It's actually one of only 6 provincially funded episodic virtual care clinics, and it runs 7 days a week from 11 a.m. to 9 p.m. Francis says it's run by 16 full-time and part-time nurse practitioners who offer care to patients just like they do in the clinic. They order blood work, refer you to a specialist, connect you with community resources, or they can refer you to your closest Ontario health team if you need to be seen in person. And I should say, it's not even just serving patients in Durham. They actually offer virtual care to patients from all across Eastern Ontario, including areas like Ottawa and Cornwall. Most often, patients who go there, they don't have an ongoing source of primary care. They don't have a family doctor or nurse practitioner they can regularly see, but they may have visited a social services agency that's connected to Durham Community Health Centre, and so they're referred to this virtual clinic. And then here, they get access to kind of a health concierge team who help with things like making sure there's an accurate record of their medications and ensuring that the patient's full history and vaccinations are really in the medical record. Then the patient's paired with one of the community ambassadors we talked about who help connect them with more services or resources if needed in the community. Plus, there's a mobile clinic that can help offer in-person episodic care for patients within Durham region. But ultimately, the clinic is designed to try and support them to transition to ongoing primary care.
And do they see them on an ongoing basis virtually, or is it kind of temporizing until they can be permanently attached?
Some of them, they can see them constantly, but what is unique with that, they see them more than once. They've done all this assessment. This individual, they become a ready-to-attach patient, which means if in Cornwall there's a physician who is new, who is attaching, because this patient has been seen several times, they have the history, the meds, everything that's there. They are ready to attach to this physician because all the needed information has been done. So they will actually forward that whole file. It's a model that is really respected by most physicians in the community because they say, no, I don't need to do all this work. It's similar to what we are also doing in the virtual clinic, in the mobile clinic.
Yes.
Yeah.
So we have a mobile clinic, which is, I call it clinic on wheels because it goes there. There's, everything is electronic in there. They see you in there, they assess you, they fill your chart. By the way, you can continue to be seen there as many times as you want. Remember, access. You are seeing the same team, which is an NP, an RIN, a social worker, a dietitian, they could be in there. And then, over a period of time, if there is Dr. Joe who has opened a new clinic, whether it's a fit, it's a fall, they are attaching. It's easy for them to take these patients that have been seen here. And we have done this several times now because we have about how many teams? 2 teams or 3 teams of mobile? 2 teams of mobile care. And then we'll be like, these patients are ready for you. And we can send along the files that we've been seeing. So as a physician who is coming in, instead of actually starting with somebody who you are picking from anyway, sometimes it's too much time and high risk. So this patient who has been established is a prime patient for you to take. Whilst we are doing that, we are creating space for others to come in. Remember, that clinic is, those 2 clinics, the virtual and the mobile, they are meant to permanently attach, but they will stabilize and be able to align with attaching services in the community, which is unique.
This kind of virtual clinic, it's bringing needed care to patients without family doctors with the hope of identifying particularly people who've been underserved, and by temporizing their situation and addressing what they can through that combination of episodic virtual care and support from social services, and then eventually, hopefully, transitioning them to ongoing primary care. Durham has pulled together such innovative programming, and one of the reasons they can do all these things is because they have a unique team of medical professionals who actually also have community organizing chops, like Kirk.
And it's called, what did you say it again?
Black Health and Wellness Day.
The Black Health and Wellness Day. Yeah. Mm-hmm.
I guess long and short story of it. When I started, DCHC would run a symposium every year. I think started 2022. And we would invite people that work in the industry to come on down and do what a symposium does around Black health and wellness. And when I started here in this position, because it's new, I said, you know what? I want it to be community facing, and I want the community to have as much say as possible in what that should look like. So I invited as many community members as possible, partners as possible that DCHC was already connected with, and then told them to invite other people. And the point of that was to have them share how they want us to have health be manifesting in the community. And as a part of that, through conversation, we decided that we want to have a day dedicated to Black health and wellness. And as a team, we decided to do that. It's a very important task because with all the changes, especially, and we didn't know about, down south and how that was going to change in terms of how, diversity, equity, and inclusion is going to look. We had no precursor for that. But we felt in terms of legacy and making sure after Black History Month, we still spoke about Black people. We decided we weren't even going to do it in February. We decided to take it out of February and push it into March. We wanted the first day of March to be highlighted as the focal point.
Wonderful.
And so last year it was the theme was proclamation for obvious reasons, but then this year it's agency. And it builds on exactly what you said. I don't think accountability should be where the community wags their finger at us.
No,
in fact, they should wag their fingers at themselves. And so we're giving them, my job is to give them the space to invest time, energy, input, but then also be able to measure the outcome and feel some sort of ownership to that. And I think a lot of times, and this is not just Kirk's idea, this is from seeing it manifested when I was in the States, because I worked there for a bit. I saw better outcomes from initiatives that organizations partnered with the community and have those community members come in and learn how to do things. The outcomes were way better because they knew how to market the program. They knew how to determine what was effective on a metrics that worked for the community versus our scientific metrics, right? The reason why it's health and wellness, so I think DCHC does a lot of work with the health component for the Black community. Wellness is something that we're still defining. So, for example, drumming is a big part of the Afro-Caribbean culture. And more than just, the music, but also there's a spiritual component to it. There's a healing component to it. We talk about food at this year's Black Health and Wellness Day event. We looked at how food is so important. Like when we talk about diabetes, for example, instead of the Mediterranean diet for hypertension or the DASH diet or whatever, we look at, okay, maybe we should look at the cultural food that's there and spend time reinforcing how it's important to live that culture, but have the awareness of health as you dash salt or put sugar in your meal or whatnot. So that's the angle that we've been taking in terms of being more sensitive in how we approach these things.
Black Health and Wellness Day is billed as a special day to honor Black heritage, break down barriers to healthcare, and create spaces for joy, healing, and collective strength. There are workshops on self-advocacy and navigating the system, wellness demonstrations, expert panels, a marketplace, drumming, and dancing, all with bilingual volunteers. And the team at Durham Community Health Centre doesn't just talk the talk. They bring their families to these events as well. And that's because, as Francis told me earlier, they actually live in this community. They're raising their families here, and so they've built a center where their own families can get access to culturally safe, community-based care. There are so many things I love about what Durham Community Health Centre is doing. Their virtual clinic is offering episodic care to those who need it most, and then helping bridge the gap to ongoing care. They're co-creating programs and services with the communities they serve. And their in-clinic services, they're deliberately designed to serve groups that have traditionally faced racism and discrimination in healthcare, specifically members of the Black community. But they're so successful that they attract other groups facing racism and discrimination as well. And then, of course, they have a variety of programs addressing the social determinants of health. And they fundraise to supplement their provincial funding to make it all possible. I should mention that this episode is part of Podcastathon, a charity event aimed at spreading awareness for charities and nonprofits all around the world. If you enjoyed this episode, feel free to visit www.podcastathon.org to discover many other charities through the voices and talents of other amazing podcasters. If you would like to donate to help fund the amazing work Francis and his team are doing here at Durham Community Health Centre, check out our show notes to find a link to their website, durhamchc.ca. A big thanks to my colleagues Dr. Aisha Lofters and Melanie Henry, who helped me with this episode. Thanks too to Dr. Kirk Stewart and Dr. Akeem Stewart for their graciousness in being interviewed by me. Thanks to Pauline Mbugwa for helping organize the visit. And special thanks to Francis Garwe for encouraging me to come and visit Durham Community Health Centre and taking the time to give me such an incredible tour. Primary Focus was created by me, Dr. Tara Kiran, and is made possible by funding from the MAP Center for Urban Health Solutions, St. Michael's Foundation, and the Max Bell Foundation. Miriam Danash is our research assistant, Seema Marwaha and Emily Holton are our creative advisors, and our producer is Avery Moore-Kloss. If you'd like to read more content from me about Canada's primary care system, join our Substack newsletter at primaryfocus.substack.com or visit our website, primaryfocus.ca. For more information on the Our Care Standard and the public's vision for a better primary care system, visit ourcare.ca. Family doctors in Canada who are listening to this episode can claim MainPro credits by completing a linking learning exercise. See the show notes for more information. And finally, if you're enjoying this podcast, I hope you'll share it in your networks. It's only through enlarging the conversation about primary care in this country that we're ever really going to affect system change. And if you have cool ideas for topics or places I can visit and feature in our podcast, please do reach out at primary.focus@unityhealth.to. The information shared in this podcast is for educational and informational purposes only. It's not intended as medical advice and should not be used as a substitute for professional medical care, diagnosis, or treatment. Always consult with a qualified healthcare professional before making any medical decisions or changes to your health routine. The views expressed in this podcast are those of the speakers and do not necessarily reflect the views of any organizations I may be affiliated with. Side effects of listening to this podcast may include a strong impulse to help fix the primary care crisis in Canada, a feeling of anger over how many Canadians do not have access to primary care, increased feelings of empathy toward primary care professionals who are just trying to make it work, and intermittent visions of hope that we can find a better way.